Hello and welcome to another exciting lecture for human sexuality. In this lecture we will be talking about sexual response and sexual problems. So we are going to look first at sexual expression, then we're going to look at sexual response, sexual function, and sexual dysfunction. So before we get into the biology of sexual response, let's talk about some options for sexual expression. And the thing is, there is a lot. Celibacy is an option for sexual expression, so not having sex at all in any way, shape, or form, not having any sexual arousal is a sexual option for sexual expression. Autoerotic behaviors is an option. This is where someone is alone, so sexual fantasies, masturbation, that type of thing. Kissing and erotic touching, where you're not even getting to what would be classified as sex, but this is also an option for sexual expression. This is the option some people choose to stop at before marriage. There's manual stimulation, and this is manual stimulation of your partner to make it different from masturbation. There's oral and genital stimulation, oral, genital specifically. There is vaginal intercourse, and there is anal intercourse. So as you can see, there is a lot of different options for sexual expression that people can have. And then even within each of these, there's many subcategories. There's many different things that can be done. It's not as easy as just this list. You could go into each of these in much more detail. We are not going to go into that in this class. We're just going to look at these broad categories of sexual expression. But we are going to talk a bit about variant sexual behavior. So variant sexual behavior is going to be sexual expression that is different than what would be normal or standard. It doesn't necessarily mean bad. Some are bad, some aren't, but it is different than what is standard or standard normal. The first is group sex. So instead of just two people, you've got more than two people. Anyone from 3 up is counted as group sex. Transvestism, which we will talk about later, which is basically dressing in the clothes of the opposite sex. This is different than transgendered, whereas transgendered is, I should say transvestism is dressing in the clothes of the opposite gender, because transgender is viewing yourself as the opposite gender, whereas transvestism is not. It is just dressing up, or sometimes it's even looked at as deriving arousal from dressing up as the opposite gender. Fetishism, we'll talk about this a little bit more later and what exactly fetishism is. Related to that, we've got exhibitionism and voyeurism. Those are two categories that have a lot of overlap. We will look at those. Sadism and masochism also have a lot of overlap. We'll look at those as well. The philias. The philias, again, this isn't necessarily bad. It's only philias when it's expressed towards a unwilling or someone who is unable to give consent, such as the young. But we have philias where philias are different things that cause arousal, different than fetishism, which we'll talk about in a bit. But the philias, you can have philias for specific things that aren't illegal. The ones that are illegal, such as if you've got a philia towards underage individuals, that is where it is bad, it is illegal. Final one, just to throw in here, it falls under fetishism a bit. All of these last ones do fall under fetishism, but autoerotic asphyxiation, where you derive pleasure from lack of oxygen, so choking. So now let's actually get into sexual response. And within sexual response, there are stages. We're going to look at this in a few different ways. We're going to look at the universals of stages, And then we will look at the difference in stages in males and female, and then we'll even look at a different view of these stages. So first is excitement or arousal. This is where vasocongestion starts. So there's increased blood flow that causes swelling of the genitals in both males and females. So this is something that stimulates a male and female genital response. This is the beginning, where excitement or arousal occurs. Vasocongestion, this excitement or arousal, does not need to come from necessarily something that someone finds sexually interesting. This can come from just a simple act of rubbing or contact. It doesn't need to, so this first stage, that's a big thing to separate this first stage. So this first stage typically comes from things that cause arousal, normal things that would cause psychological arousal, but can come from things that just cause physical arousal that are not psychologically arousing. You can wear a pair of pants that rub just the wrong way and it causes arousal. That doesn't mean that it's the pants that's making you well, it's the pants that's making you aroused. It doesn't mean the pants are making you psychologically aroused, mentally aroused. It's just making you physically aroused. And this is where we'll put one of those separations. When we talked about development, sexual development, one of the things we talked about is that sexual response occurs throughout the lifespan, even in the womb. And that comes from more of this, not the psychological arousal, just the physical arousal. The next is the plateau. So the plateau is going to be where there is voluntary and involuntary muscle tensions increasing. This is the period of time after arousal, before orgasm, where you sit at a point where the arousal is full on and it continues. That's a big thing to consider with the plateau, is it's where the arousal continues. Then you have the orgasm. The orgasm is where this vasocongestion, that increased blood flow, and muscle tension reach a peak, and rhythmic contractions occur throughout the genital regions. Again, this is in both males and females. So these rhythmic contractions occur, and you have orgasm. And then finally, you've got resolution, where muscle tension and congested blood subside. So we are going to talk about the fact, and when we look at different ones, where you can actually go from orgasm back to plateau. Males can do it too. Females, it's much more common. Males can do it. It is much less common and much more difficult to occur, but you can go from orgasm back to plateau, and you can go from plateau to resolution. You do not have, orgasm is not a required step there, but you can also go from orgasm to resolution. You can actually go from excitement to resolution too. You don't have to reach plateau to go to resolution. So all of these can result in resolution. We'll talk about refractory periods and things like that when we're talking about these stages in a little bit different way in just a little bit. So let's look at these stages. So on the left you have males, on the right you have females. So the excitement and arousal, you get erection occurring. For the testes, the testes will elevate and the scrotal skin will tense and thicken for the excitement phase. For females, the uterus elevates. You'll see when we get to the resolution phase in just a minute that it's actually, you see this arrow here, because the uterus actually sets more on top of the bladder when arousal is not occurring. So the uterus elevates, the clitoris enlarges just like the penis does, vaginal lubrication will begin, and the inner labia will start to swell. In the plateau phase, so this is where in males, the erection will get firmer and larger, a big important thing is that fluids start to be released. There can be sperm in this fluid, but they're very few. But these are to aid in lubrication. We talked about the stages in development before, and how these fluids help in clearing out the acidity of the urethra and the penis, and as well as some of the vagina. The testes become completely elevated. In females, the uterus completely elevates and increases in size and thickness. So then the inner 2/3 of the vagina expands and lengthens to accommodate for the penis. The outer 2/3 forms the orgasmic platform, which is where the orgasms will occur. The clitoral hood, basically the clitoris retracts under the hood. This allows for protection but still stimulation. So then you've got the final two phases, orgasmic phase or orgasm. So in males, you get the contractions of the vas deferens, the seminal vesicles expel sperm into the urethra, the prostate expels fluid. All of that stuff we talked about before. One of the things we didn't talk about in the previous lecture is that the rectal sphincter contracts during orgasm, and sperm and semen are expelled. In females' orgasm, the uterus will contract during orgasm. The orgasmic platform will also contract, which will squeeze in this region, and the rectal sphincter contracts as well. So in females, you get contractions in the uterus and in the orgasmic platform, which is towards the opening. Then you get resolution. In males, the erection subsides and the testes descend, the scrotum then thins and the folds return. In females, on the other hand, you get the uterus that shrinks and returns to its normal position. So I told you I would come back to this. You see how it is different in this picture than it is up here, in that the uterus comes down on top of the bladder. The vagina returns to its unaroused position, the cervix drops to its unaroused position, the clitoris descends to its unaroused position. Basically, everything goes back to the unaroused position. But like I said before, don't be confused. Don't think that this comes immediately after orgasm. You do have the fact that you can go back into the plateau from orgasm. So let's look at the orgasm a little bit more, and then we'll look at some models of how this all works that's slightly different than what I just explained. So the orgasm is the climax of sexual arousal. And there is actually similar physiological response to sexual stimulation for men and women. So this response is very similar in the way it happens for men and women. In men, you have contractions in the testes and all the way through. In women, you have contractions in the uterus and all the way through. So it's very similar between the two. The only big difference is the resolution phase. The refraction phase for men tends to be much stronger, but women even have that as well, just to a lesser extent. So it's described by Kaplan as a 3-stage model of sexual response. Let's look at these 3 stages. So Kaplan's model is pretty similar to what we already talked about, but slightly different. So stage 1 is desire. So this is where the drive and interest level for sexual activity arises in the brain. Testosterone is the key hormone for desire in both men and women. So we talked about how women have testosterone. Well, testosterone comes down to it is the driving force for sexual desire in both men and women. It is why in general women have, one of the reasons why in general women have lower sexual arousal or lower sex drive. We talked about a lot of the evolutionary reasons, but one of the actual biological reasons is because they tend to have lower levels of testosterone. They do have lower levels of testosterone. This desire can be strengthened by fantasy and stimulation. So we already talked about that. I'm not going to go into that more. Just it's something that can increase desire and get you to that plateau. So stage 2 is excitement. This is that stage where you've got the increased muscle tension, heart rate increases, blood pressure increases. For women, you've got a enlarged clitoris, labia, and vagina, and vaginal lubrication. For men, you get penile erection, enlargement and elevation of the testes, and cowper secretions, which I already talked about. The things, what they're designed to do, basically, to reduce the acidity of the urethra as well as the vagina, and aid in lubrication. Then we get to stage 3, which is again the KAPLAN'S model. The stage 3 is the important stage of it, and this is where the involuntary muscle spasms throughout the body. So the other model talked about it just in the sexual organs, but Kaplan looked at it and realized that these muscle spasms are actually happening throughout the body. Yes, mostly in the vagina and the penis, but throughout the body. Also looked at blood pressure and heart rate. During this time, blood pressure peaks, heart rate peaks. Heart rate can actually peak shortly after this in men, but it is getting close to peak when orgasm occurs, and respiration peaks. And as I said before, there is differences between men and women. One of the things is it can be longer in women. It isn't always necessarily longer, but on average it's slightly longer in females. And again, the periods we're going to talk about afterwards, like refractory periods and stuff like that, are different or less for females. Let's look at sexual functions and the difference between men and women. So first, you've got, in men, the erection. So this is where the enlargement and stiffening of the penis is a consequence of filling with blood. This is a spinal reflex, meaning you can have an erection even if you've got spinal damage, because you don't have to have communication that comes all the way from the brain. It comes from the spine. So if you've got a severing of your spine, the rest of the spine still works below, so you can still have this spinal reflex. So someone who's a paraplegic, quadriplegic can still have an erection because it's a spinal reflex. It can double in length and become firm in a matter of 10 to 15 seconds. And we're not going to talk about it too much here, but the doubling in length is average, and it can grow up to 4 to 5 times the size. It is variable in how much of an increase in size comes from between non-erect and erect. There is actually much less variance in erect size than there is in non-erect size. And during arousal, bladder closes off. Basically, it doesn't mean that the guy cannot urinate, because it is possible to. It just means it is much more difficult, and the feeling of needing to urinate decreases during arousal. It doesn't go away, but it decreases. As far as the ejaculation phase, this is the expulsion of sperm from the tip of the penis. This is also a spinal reflex. So this is a spinal reflex triggered when stimulation reaches a threshold. The cognitive, what's going on in the mind, can influence this spinal reflex, but it's not necessary for this spinal reflex. So again, those who have spinal injuries, who are paraplegics, they can still get an erection and they can still have an ejaculation, so they can still have kids. It doesn't guarantee it's going to happen, but it does. It is possible, because it is it is something that is not necessary for you to have the mental side of it. However, it is often, but not always, occurring with an orgasm. Orgasm is going to be those subjective sensations, and this is where the cognitive side of things comes in. And this is where, in those that are paraplegics, they can ejaculate and won't necessarily have an orgasm, because an orgasm is then mixing those that cognitive side with the physical expulsion of sperm. It does occur in 2 stages. Let's look at those. The first stage is emission. So this involves the contractions of the prostate gland, the seminal vesicles, and the vas deferens. This is what forces the seminal fluid into the small tubes called the urethral bulb, which closes at both ends, trapping the fluid. So this is the stage 1 is the emission. So this is where basically where the prostate gland, the seminal vesicles, the vas deferens are all basically storing up their fluids, and it's stored up in the urethral bulb, and the fluids are then trapped there in preparation for the next stage, which is expulsion. So this is the propulsion of that seminal fluid through the urethra and out the urethra opening at the tip of the penis. So again, it's all released as you're getting close. It's stored at the beginning of orgasm. It starts to be stored, and then at the second half of orgasm, it is expelled. So the muscle at the base of the penis contracts rhythmically, expelling the sperm from the bulb there. And between each expulsion, there is more that's stored in that bulb. So that's where you get expulsion comes in waves, in segments. So between each expulsion, as some is being pushed out, new stuff is being pushed into the bulb and stored in the bulb, and then another expulsion occurs. So it's a rhythmic expelling of the semen. And this is, as I said before, usually accompanied by orgasm, but not always. Relating to that, you can have retrograde ejaculation. So retrograde ejaculation, sometimes called a dry orgasm, is when the ejaculate empties into the bladder rather than being expelled. So the result is, as I said, what's referred to as a dry orgasm, an orgasm that occurs without ejaculate. And this is usually harmless because the semen is later expelled. But if this occurs, especially if it occurs more than once, if it only occurs once, I wouldn't be concerned. But especially if it occurs regularly, this is usually due to an underlying health risk and should be checked out. You should consult a doctor if that's the case. Sexual response is related to things like pheromones. So we look at pheromones as something that's talked about. So pheromones are chemical substances. They're secreted externally. They are mostly odorless. They are not necessarily completely odorous. Pheromones, just like MHC, is something that we can pick up and detect. And it does, when detected through scent triggering, it does result in sexual arousal in many organisms. It's contained both in vaginal secretions and in urine. So this is something that and it can be even secreted from underarms in various different ways. But the main places in humans is through vaginal secretions in urine. So it is a thing that can trigger sexual behavior in many organisms, including in humans. It has a lower effect in humans than in many other species, but it still does have an effect. That brings us to the question, though, of aphrodisiacs. So aphrodisiacs are supposed to be substances that arouse or increase one's capacity for sexual pleasure. These are supposed to be things that help us increase pheromones or reduce pheromones themselves. However, no food has been shown scientifically to be sexually stimulating. Certain people have fetishes that relate to food, so for them food will have an arousal, but typically it's most foods or all foods in certain categories. Universally across humans, though, there's no food that has been shown to be sexually stimulating. The things you can get for aphrodisiacs and pheromones, like Spanish fly, it's actually a toxic irritant. It can cause way more harm than good. The basic fuel of desire is testosterone. So the only way to necessarily increase desire is through testosterone. We'll talk about some of the disorders in just a little bit, but one of the interesting things is those who have sexual desire disorders, one of the main things they're prescribed is a testosterone cream that they rub on their not on their genital regions, but on their pubic regions, over the pubic bone. And this can actually, what it does is it absorbs the testosterone and it can increase sexual desire. So let's talk about masturbation real quick. So masturbation, pretty obvious, sexual self-stimulation. Masturbation can be either manual or actually with the aid of other artificial devices, or even with the aid of others. It becomes a less about solo masturbation, and you can have types of joint masturbation. So artificial devices such as vibrators that work, there are things for both men and women that are for aiding in masturbation. As far as all the studies show, it's physically and psychologically harmless. All the things you hear, you grow hair, it reduces sperm count, it is harming. No, all the studies, every single one of the studies shows that it's both physically and psychologically harmless. The only big thing that can come of it is there's negative attitudes that can be associated with it. So it can, when I say psychologically harmless, I mean in normal situations, it can be psychologically harmful for those who feel shame when they do it due to the attitudes relating to it. Nearly everybody does masturbation. Nearly everybody, there's very, very few people who do not masturbate. Some masturbate more than others, some masturbate less, but the fact of the matter is it's pretty much a human universal. People from all cultures do it. What you actually find is that in cultures where there's these negative attitudes about it, that's where it occurs less, but it still occurs. And one of the tangential things that's actually occurred in the cultures where there's very big negative societal or religious regions, big things against masturbation, is people who come from those cultures have a higher rate of other sexual dysfunctions, specifically relating to harmful fetishes and harmful philias that we'll talk about. So it's almost as if bottling it up and not masturbating actually causes other psychological issues. So why do people masturbate? One of the main reasons is just to relieve sexual tension. If you've got sexual tension, masturbating relieves that. Some people do it, many do it for pleasure, just because it feels good. Some do it to relax. If you're stressed out, if there's something bothering you, masturbation can help you relax. If your partner's unavailable, to get to sleep. Some people, they can't sleep when they have a minor amount of arousal, or even if without the arousal, they might not be able to sleep, and after masturbating can fall asleep. So that is something to consider. There is a lot of reasons, not just sexual reasons, for masturbation. Okay, let's look at some sexual response amongst older adults. So we're talking about people who are older. We're looking at older than 40, 50, 60, maybe even older than that. So in women, in postmenopausal, their bodies, the skin in the vagina becomes less elastic, which can cause pain. It can cause issues there. Vaginal lubrication does decrease, which again can cause pain. The vaginal walls become thinner. Again, pain is relating to this. The internal organ shrinks, so this can cause a decrease in the region of the vagina. So all of these together mean that there are changes that need to be taken into account when it comes for postmenopausal women having sex. Sex in postmenopausal women is perfectly normal. It does occur. It's just the big thing is maybe external lubrication needs to be added, or other things like that. Things need to be taken into account. In men, it's a little bit along the opposite. It's more of the erection is less consistent and stable. So achieving an erection becomes more difficult. It sometimes requires more direct and prolonged stimulation. The erection can be less firm. The intensity of the ejaculate decreases. So it's kind of in the opposite direction for men. It's more along the lines of more difficulty engaging in sex, whereas women have more difficulty during sex. Okay, let's go through the sexual dysfunctions. I've got some of them here. I don't actually put all of them in this segment. There is more than this in the DSM. There is more than this to consider. If you take abnormal, you talk about more of these. But what I'm going to do is I'm going to spend a little bit more time on them than I would talk about how these work. So sexual dysfunctions involve desire, arousal, and or orgasm, or they involve pain associated with sex that can lead to additional dysfunction. So there's a lot of different things here. It can involve just plain desire. The rest can be present, but desire is not. It can apply to just arousal, so the ability to get sexually aroused. The desire could be there, but arousal is dysfunctional. And it can also involve just orgasm. So desire and arousal are there, but there's an issue with orgasm. And then the other side of the equation is pain. Pain during sex can cause a reciprocal backlash on desire, arousal, and orgasm. However, for these to be a dysfunction, just like anything else in abnormal psychology, it must lead to an impairment or distress in order to be considered a disorder. If somebody doesn't have desire, arousal, any of that, and to them it is not causing them distress or impairment, it is not a disorder. So straight up, being asexual, there's many different types of asexuality, but the type of asexuality where you don't have sexual desire, that is perfectly normal if to that person it is not causing impairment or distress. If somebody doesn't have desire and it is causing them distress, they want to have desire and arousal, then it would be classified as a dysfunction. So let's look at some things like prevalence. First off, sexual dysfunctions are actually extremely common. They're not always distressing. 40% of men had some difficulty with erection or ejaculation at some point. 63% of women have problems with arousal or orgasm. It's not always distressing. It's not always what would be considered a sexual dysfunction. Again, you have a guy has a problem with an erection once or twice or every now and then, as long as it's not causing distress in that relationship, then it is not that big of a deal. If it's causing distress, yeah, then it becomes a big deal. If it's something that's occurring regularly, then that's something to be concerned about. These dysfunctions we're going to talk about, there's actually parallel versions between men and women. So many of the disorders that we'll talk about, there's a male version to a female version. So the first one we're going to talk about is male hypoactive sexual desire disorder. So hypo means diminished or less. Hyper means more, hypo means less. So hypoactive, less active sexual desire disorder. So in males, this is the disorder where males have little or no interest in any type of sexual activity. For people with this disorder, even masturbation and sexual fantasies are rare. The intercourse is rare as well, but even sexual fantasies is rare. Masturbation is rare. And this does affect up to 5% of men. It is much more common in older men than it is in younger men, but it is not absent in younger men. So again, hypoactive sexual desire disorder, little or no interest in sex at all. This is one that's going to typically be related to low levels of testosterone. So low T, and the way this one is treated is with testosterone. So you treat it with testosterone, it increases desire for sexual activity. So this is going to be in individuals who have abnormally low testosterone. And as I talked about before, testosterone diminishes throughout the lifespan, so this is why it does affect older men more than it does younger men. Conversely, you have female sexual interest arousal disorder. There's no hypoactive word in here, it's just female sexual interest arousal disorder. This is the same thing in females, but it is a lack or significantly reduced sexual interest or arousal. Typically manifests in reduced sexual interest, reduced sexual activity, reduced sexual thoughts, reduced arousal to sexual cues. That's a big one with this one. So even if the sexual cues are present, arousal is diminished. And those who do engage in sexual encounters have reduced pleasure and or sexual sensation from sexual encounters. So it's reduced sexual interest, but also reduced sexual satisfaction or pleasure. So that's a big one to look at, that it doesn't just affect, this one doesn't just affect interest and arousal, this affects it all the way through, all the way to pleasure. And again, just like in men, this is treated by testosterone, by giving testosterone. And again, this is a androgen gel that is given to women who have reduced sexual desire. And this androgen gel is typically applied to above the pubic bone, in the region above and around where the pubic hair is. So it's not applied directly to the vagina. It's not a something that's ingested, but it's a gel that is basically absorbed through the skin, that is applied over the pubic region. The next one we'll talk about is erectile disorder. So erectile disorder is a bit different than hypoactive disorder. Hypoactive was in reduced desire. However, erectile dysfunction, sexual desire is typically still there. There are some instances, but we'll come to that as the caveat in a minute. So sexual desire is still there. However, there is now a difficulty achieving or maintaining an erection. So the erection is the issue, not the desire. There is instances where there's a reduced desire as well. This is more when you get a cognitive issue. So erectile disorder isn't a cognitive issue. Erectile disorder is a biological issue, typically. When desire is still there, but the difficulty achieving and maintaining the erection is not. So the difficulty in achieving and maintaining erection is what's the problem, but the desire is still there, then it's more of a biological issue. The blood flow just isn't working right. All of that isn't working right. It's not necessarily a psychological. It can be, you can have psychological, but there is certain psychological conditions that cause a reduce in desire, which then results in a reduce in erection as well. The prevalence of this increases with age. 60% of men over 60 experience erectile dysfunction at least intermittently, and the treatment for this is going to be things like Viagra. So Viagra, a drug that was originally designed for something entirely different, found out that it results in erection. So that biological issue, the blood pressure issue, things like that, are taken care of with a pill in this case Viagra. There's other ones out there that do a similar thing that basically account for that biological issue resulting in erection. However, the one thing most people don't realize is things like Viagra still require desire for the erection to occur. The erection doesn't occur out of the blue. No, the desire still has to be there. Similar in women is so female orgasmic disorder. This is where women, even if they have so desire is still present, there's a delay, absence, or decreased intensity of orgasm in almost all sexual encounters. It can't be explained by relationship distress or other significant distressors. Again, it can't be a cognitive issue. This is more of a biological issue. If there's a cognitive issue, then the cognitive issue is what the disorder is. It just happens to be this is a symptom of that cognitive issue. Female orgasmic disorder is not a cognitive, it's biological, and as many as 1 in 4 women have significant difficulty achieving orgasm. And with this one, again, there are pills to treat this. There's not as many pills, it's not as well researched as within men, because all the drug research tends to go to men, but there is pills for women that will help with this itself. So again, sexual desire is intact, but the ability to achieve orgasm or the intensity of orgasm is diminished. So in this case, it's one of those where a pill that has a biological change can fix that. Conversely, in males, there's one that really isn't so the next two, there's not an analogy between male and female. We're going to talk about one male disorder and one female disorder, but there's not analogies between the two. The first is in males, premature ejaculation. That is where ejaculation occurs within 1 minute of penetration before it's desired. That's the big thing. If it's desired to occur in that time, if the guy is trying to have ejaculation that quick, then it is not premature ejaculation. It is not a disorder. It has to be before it's desired. And within 1 minute of penetration, again, this is even before penetration. So if it happens before penetration as well, it's counted as premature ejaculation, again, if it's before it's desired. This is the most prevalent sexual dysfunction in younger adult males. Again, erectile dysfunction is more prevalent in older adult males. In younger adult males, this is the most prevalent sexual dysfunction, and it actually affects about 1 in 5 of all adult males. Most of them are, though, going to be younger and inexperienced. So I'll even bring the next line up. With age, this problem tends to decline or go away. In most individuals, this declines with age. There's no drugs for this. There's more therapies and techniques. So men are taught Kegels, different types of techniques that they can do to reduce this. Other things that are recommended to treat this are things like masturbating before sex. Then it gets a lot of that out of the way. And though men, when they have sex repeatedly or a second time, they tend to last longer. I just realized that I took out the stuff on refractory periods from earlier in the slides, so I apologize for that. But refractory periods, just to go over that real quick, is the period after ejaculation before sexual arousal can happen again. Men and women both have refractory periods, though in women it tends to be very small, very quickly gotten over. But in men it tends to be longer, but there are circumstances where the refractory period can be short enough where plateau does not go away, where the erection doesn't go away. In males, they tend to lose their erection and have to gain it again, though you can have instances where the erection doesn't go away. It's related to this, that's why I bring it up, because after the refractory period, if males that engage in sex again, it tends to take, it typically and almost always takes longer to reach ejaculation. So this is one way to account for or make up for premature ejaculation. The last disorder I'm going to talk about here is the one that's unique to females, and this one is actually a pretty serious disorder. This is one of the ones, I mean, you have erectile dysfunction, you can have drugs to treat it. You've got premature ejaculation, there's techniques you can do to treat it. We'll talk about things that there is that can be done for this one as well, but this one is the one that actually causes a lot of psychological and emotional distress. This is genito-pelvic pain penetration disorder. So this is in females who have difficulty with vaginal penetration during intercourse. So basically any vaginal penetration can cause pain here. We're not talking about when there's a lack of lubrication. We're talking about a general pain that occurs during intercourse or penetration attempts. And it can lead to fear or anxiety about pain during sexual activity. So when this pain occurs the first time, women tend to have fear or anxiety about the pain occurring again. Because they have anxiety, there tends to be a tensing of the pelvic floor muscles in anticipation of sexual activity due to this fear and anxiety. And this tensing of the pelvic floor muscles leads to a vaginal opening that's too small, that leads to pain during intercourse and penetration attempts again, which then leads to fear, which then leads to tensing, which then leads to more pain, to the point where women who have this just stop trying to have sex. They may still have sexual arousal. They may have sexual desire, but they have no desire to actually have sex because of this fear and anxiety due to the pain that they've been caused before. And like I said, this is can be really psychologically and emotionally draining and just harmful, because in these cases the women who have this really want to have sex, but they can't because of the pain, the intense pain that's caused. And again, this pain isn't due to lack of lubrication. It most of the time, but not always, is due to tensing of the pelvic floor muscles, which makes the opening too small, which causes basically too much rubbing and bruising. It can occur due to nerve endings. So there's one individual I know who, when she gave birth to a baby that was too big, and they basically had to cut part of her vagina open, which is something that does occur sometimes during birth. But in that region where the cut was, after it healed, she still occasionally has pain in that region during sex, even years later. I believe her kid is something like, the last time, the kid's something like 18, and she still has pain during sex even 18 years later sometimes. As far as what you can do for this, again, Kegel exercises, learning to control the muscles of the pelvic floor is something that is the strongest thing that's recommended for this, because then women who have this can learn to relax that. The numbers I hear is as many as 20% of women can actually suffer from this disorder at points in time in their life. So it's a pretty serious disorder. The last thing I didn't talk about with that last one is relaxation exercises. Treating the fear and anxiety is one thing that you can do to treat that as well. Okay, let's look at sexual dysfunction real quick, just relating to drugs and sex. As a consequence of drinking, about 15% of college men and 12% of college women have unprotected sex. Drugs, alcohol, various different things like that can have cause people to do things that they regret later. I wouldn't say cause, can increase the probability that they do something that they'll regret later. It can result in poorer decision making. It can result in people putting themselves in compromising situations. Not going to victim blame at all here, just going to point out that as a result of drugs, alcohol, things like that, people do things, both have sex when they're not intending to, have sex without protection when they really wanted to have protection, or put themselves in situations where the harm comes to them. Again, not victim blaming, just saying that the drugs and alcohol can lead to these types of things. So it is one of those things that really should be considered. Doing drugs, drinking alcohol, these types of things that impair judgment. If you prepare yourself ahead of time, it can reduce the amount of impaired judgment, or if the impaired judgment occurs, it can reduce the consequences of the impaired judgment by ahead of time being aware of what can occur as a result of drugs and alcohol. The next lecture, we're going to talk about sexual assault and things like that, and we'll get into some of the things relating to that. And again, I want to strongly emphasize, I am not victim blaming. It is not the responsibility of the person who put themselves in the compromising position. The guys or girls, because both commit the act, it is the aggressor who shouldn't be doing what they're doing. It's just, we do have to take into consideration the impact of drugs and alcohol on the outcomes. Okay, so in this lecture we talked about sexual expression, we talked about sexual response, we talked about sexual function, and we finished with sexual dysfunction. Thanks, come on back.